So good evening everyone, a warm welcome on behalf of MSD. We know that the role of immunotherapy in recurrent and metastatic head and neck cancer is well established. But when it comes to locally advanced head and neck cancer, the role of immunotherapy is still evolving. So this will be a great privilege for MSD to collaborate with Indian Society of Oncology to have this platform to discuss this evolving role of immunotherapy in the treatment of head and neck cancer. And this platform will definitely help to focusing on the practical, real life examples, practical recommendations, which will be useful for all the oncologists which are here participating in this event. It's my privilege to invite Dr. Toprani sir. Thank you so much, sir, for giving us this opportunity to collaborate with Indian Society of Oncology to discuss this evolving science for all the oncologists. I think sir does not require any introduction in his like executive committee member of multiple societies like Indian Society of Oncology, Indian Society of Surgical Oncology. Sir, I'll invite you for giving the context for this meeting. Thank you.
Good evening to one and all, and I also welcome those who have joined online. As was mentioned earlier, the evolving role of immunotherapy is at a very interesting phase, and I'll take you back. We have been practicing for last 3 decades, myself and Chirag and Dr. Bhavesh and all. And what we have seen is the evolving role of systemic therapy in general in the last 3 decades. So when cisplatinum was into practice, we thought that we have got some magic bullet, but it did not happen so. And then subsequently we got all the taxanes and all, but nothing changed the management of locally advanced head and neck cancers or recurrent or metastatic cancers. We could not achieve that much of benefit. Then we got then there was some role of cetuximab, some targeted therapies, and still we did not find any huge benefit out of the use of this systemic therapy. But the role of immunotherapy has been very interesting, and there are a lot of positive trials for recurrent metastatic unresectable disease. And what is evolving now is the role of immunotherapy into locally advanced head and neck cancer, whether in neoadjuvant setting or for organ preservation also in some of the regimens. And then one step going forward today, Dr. Bhavesh is going to talk about the evolving role of immunotherapy into early stage head and neck cancers also. So we are at a very interesting stage as far as immunotherapy is concerned, and I hope the next decade would belong to the immunotherapy regimens, and we would be able to make some definite benefit for the patient. So let us see what our experts have to say and their practical experience also. So I would invite now the first speaker, Dr. Bhavesh Parekh. He's a very good friend of mine, and he has been a senior medical oncologist and practicing as the director of medical oncology at SIMS in Ahmedabad. So Dr. Bhavesh, please.
Good evening all, and thank you MSD and thank you ISO and thank you Chairperson. My topic is clinical application of immune checkpoint inhibitor in early stage. Whenever we talk about head and neck cancer and especially early stage, most of the time it is a surgical domain. And still there are some cases, what I also run through the various slides, that some case is inoperable or borderline operable. Rather than inoperable, the word is borderline operable, where surgeon feels to discuss with the tumor board or to discuss with the radiation oncology or medical oncology, can we downstage, or can we help by giving some systemic chemotherapy? And as Dr. Toprani says, it is the cisplatinum or docetaxel either, or maybe cetuximab. But finally, it is now we are talking about immune checkpoint inhibitors. So again, this scientific discussion MSD supports with approved indication. So first polling question is, or to start our discussion in the audience also, has there been a positive trial evaluating the addition of immune checkpoint inhibitor therapy to chemoradiation in patients with locally advanced squamous cell carcinoma of head and neck thus far? So Samir, Siti, like yes, no, yes, but addition to was associated with intolerable adverse event. Out of 3, any guess, any answer, Kshitij? Absolutely. So that's the basis why we are discussing today, that we all feel that there is no much benefit or there is no advantage. So background is that immunotherapy, how it acts. This is the radiation given to the cancer cells, and then concurrent chemoradiation, and finally the immune stimulatory signals, and that signals is very important, and that's DC activation, and that's in the lymph node, and ultimately immunotherapy will help. So I am going to discuss 2 or 3 trials, and in 2 or 3 trials, the primary result of this first trial is the phase 3 Javelin head and neck 100 trial. See, this is the phase 3, and where it was used avelumumab, and that avelumumab plus concurrent chemoradiation followed by avelumumab maintenance. So immune checkpoint inhibitor plus concurrent chemoradiation followed by maintenance immunotherapy versus only chemoradiation in patients with locally advanced squamous cell carcinoma. And that's by Mary Mardew and Michael Wong. Again, if we look to the trials, the patient histological diagnosed previously untreated high risk, the word high risk. And high risk in the bottom line they mention about that oral cavity, oropharynx, larynx or hypopharynx, HPV negative, stage 3, 4A, 4B. Non-oropharyngeal HPV positive also they included, and that stage 3, 4A, 4B, and HPV positive oropharyngeal disease but T4, N2C or N3. That is definition of high risk. So again, that high risk patients randomized initially that first week, like cetuximab, we had given 1 week, that is avelumumab 10 milligram per kilogram, followed by that concurrent CTRT phase. And in that CRT phase, that is included 9 weeks, that include avelumumab 10 milligram per kilogram every 2 weeks. The regimen is 10 milligram per kilogram, and that is every 2 weeks with cisplatinum. But generally we are giving 40 milligram per meter square weekly. Here 100 milligram per meter square. That's again 3 cycles during that chemoradiation. And again the radiation field or radiation dose is 70 gray, and that is 35 fraction over 7 weeks. So again, that is very important to know that which type of what we are doing and what this practical trial has been. And again, that has been maintained by the 12 month of avelumumab every 2 weeks. The primary endpoint and secondary endpoint is also very important. The primary endpoint is a PFS, not OS. PFS, and that is assessed by the investigator per modified RECIST 1.1, while secondary endpoint is overall survival and overall response rate and safety. This is the secondary endpoint. Now again, MSD people is also sitting here. In this trial, it was avelumumab, that is a blue line, and placebo plus concurrent CRT, that is a black line. And see that number of stratified HR 1.21. Again, p-value 0.92. And the number of patients is 350. Again, in this graph also, that is overall survival, overall patient population also. Again, treatment related AE. See here also what we feel that immunotherapy related side effect. Again, any side effect, all grade, that is 98. But if we calculate grade 3 or 4, even grade 4, it is only 14%. while in placebo it was only also in 11%. So 11 and 14 is not much difference. Again, dysphagia, that is a major problem, while hypomagnesemia and oropharyngeal pain is also a very important side effect as far as the avelumab or javelin trial is concerned. Now, to remember the point, 1, 2, 3 and 4. 1, it is the first trial that randomized phase 3 on an immune checkpoint inhibitor combined with concurrent CRT in any tumor type. The second most important, this trial was stopped due to futility, that avelumab plus concurrent followed by avelumab maintenance did not significantly improve PFS. And the third point, the CRT exposure was consistent between the avelumab and the placebo arm. Again, a higher proportion of grade 3-4 adverse event occurred in the avelumab arm, that is 80%, compared to the placebo arm, that is 74%. And the last or most important part, based on this analysis, the observed HR, hazard ratio for PFS, is numerically favored avelumab plus CRT in PD-L1 high tumor. Again, PD-L1 high. Sometimes for a metastatic, sometimes there is irrespective of PD-L1, we are giving immunotherapy. Now, I am coming to the second trial, that is Keynote 412. Again, the design of this trial, again same T3, T4, that is high risk, N2A, N3, again larynx, hypopharynx, oral cavity, P16 negative. Where P16 positive, then it is T4, N3 and it is oropharynx. Randomized 1:1, again 800 patients, pembrolizumab. Here pembrolizumab given every 3 weeks. In that trial javelin, it was avelumab every 2 weeks. Pembro 200 milligrams flat dose, and maintenance pembro for 14 cycles. 14 cycles, almost 1 year, 14 into 3. And again treatment until progressive of disease, or 17 cycles of pembro or placebo, or investigator's decision to withdraw. Here again the primary endpoint is EFS and secondary endpoint is OS, or safety oblique tolerability. Now this again, it was a phase 3 trials. Again it is with concurrent chemoradiation, and again this trial ultimately, if we look in the graph, now see the green line, and green line is pembro plus concurrent CRT rather than brown line, that is placebo. Again important, 24-month and 36-month, 63.2%, while it was 57.4% still at 36 months, and that is median is still not achieved at the end of 44.7 months. Keynote, again overall survival, if we look, again pembro plus concurrent chemoradiation, the graph, it was initially down, then again crossing, and then again coming on the upside. That is again median has not been reached. The pembro event was 32.1%, while placebo it was 35.6%, and HR is 0.90. Now, this one trial is NRG-HN004, and that is Durva versus cetuximab. And again that is in cisplatinum ineligible. This is also very important trial as far as chemo or immunotherapy is concerned, and that is again in the neoadjuvant or in a early cancer. The third trial, most important, neoadjuvant and adjuvant, both pembro plus standard of care in resectable, the word resectable, locally advanced phase 3 Keynote 689. We had previously discussed, that was Keynote 412, and now we are discussing Keynote 689. Again, the standard of care resectable, unresectable or organ sparing. The word Toprani uses, Dr. Toprani uses, or if sometimes we also want organ sparing. And that low risk, again high risk. High risk with adverse pathological features like positive or closed margin, extranodal extension, that is high risk. And phase 3 trials of the immune checkpoint inhibitor in a definitive non-surgical chemoradiation and adjuvant setting were negative. Again, word neoadjuvant immune checkpoint inhibitor may promote pathological and immune response and lower the rate of high-risk pathology. The adjuvant immune checkpoint inhibitor may prolong your locoregional control and prevent the distant metastasis. The phase 2 studies, again of neoadjuvant or adjuvant pembro in resectable, is acceptable safety and promising efficacy. The pathological response and favorable clinical outcomes. So this is open label, randomized, phase 3, keynote 689 study. Again, initially that is in neoadjuvant phase, pembro 2 cycle has been given, followed by surgery. Now randomized in adjuvant phase, either pembro 3 cycles plus CTRT or simple CTRT, post-surgery. And again in that adjuvant phase of giving immune with CTRT, also pembro maintenance or in adjuvant setting of the 12 cycles. So initially that was 2 cycles pre-op, then 3 cycles, and then followed by 12 cycles. Very important, radiation dose and the cisplatinum. Again here cisplatinum is given 100 milligram per meter square 3 weekly. Male dominance, smoker, alcohol use, primary tumor site, oropharynx is only 9.6, while oral cavity is 60%, HPV positive 3.3%, and PDL1, CPS more than 10% is 64.5%. Very important. Intent to treat population, again the patient in study, the permanently patient discontinued all study therapy at this phase is only 15.2% in pembro arm, while 11.7% in the standard of care arm. Missing patient 13.5, 13.4, both same in the study therapy, and in adjuvant therapy, again permanently discontinued all study, there was 30% in adjuvant setting, while only 4% in standard of care arm. All study treatment, the completed all study treatment is 42.7, while it was 74.4% in a standard of care arm. This is also very important. Radiation therapy, cisplatinum, median cycles, median duration both same, 1.4, 1.4, median cycles both same, 3 cycles and 3 cycles, and total dose 2200 milligram. Again 95, and that was 88.8%. Primary endpoint, see the graph, pembro versus standard of care, that is light green. Above the graph, 74% at 12% compared to 60%, 65.1 compared to 53.2, 59.8 compared to 45.9 with standard of care even at 36 months. Again, if we calculate CPS more than one population, again we are still not knowing whether to do a PDL1 or CPS scoring, but in this especially more than 1% population, it was definitely pembro arm is doing very well. Median is 59.7 in pembro arm, while it was only 30.4% in standard of care arm. All participants, irrespective of PDL1 status also, median is 51.8, while 30.4 in a standard of care arm. Again by subgroups, by age, sex, race, religion, primary tumor sites, either it is a larynx or oropharynx, only it was hypopharynx, that is hazard ratio is 2.55. Again, stage 3 or 4, PDL1 less than 50, more than 50, smoking, never smoker, former smoker or current smoker, all the 3 subgroups, pembro arm is doing much favor. Secondary endpoint, again, estimated difference, again partial response, pembro 13.7 compared to more than 10 CPS more than 10 score is compared to SOC, that is only 0.0, while it was 13.7, more than 1 9.8 versus 0, and all participant it is 9.4, and all the p value is very significant, 0.0001. Secondary endpoint, OS, again CPS more than 10% population, median not reach, while it was standard of care, it was 61.8%. Very important. Again, if we talk about the standard or adverse event, again grade 3, grade 4 or even grade 1, 2, again the most common or any things that is more important is hypothyroidism and radiation skin injury. Immune mediated, again if we having a AE but that is treated population, that is also very important, and hypothyroidism is the most important in the pembro arm. So to conclude my topic or discussion, neoadjuvant or adjuvant pembro added to standard of care significantly improved PEFS in resectable, locally advanced in all three pre-specified analysis population, that is either CPS more than 10, CPS more than 1 and all participant. The OS benefit did not reach statistical significance at 1A1, additional follow-up is ongoing. Neoadjuvant did not alter surgical completion rate. Fewer participants had post-operative high-risk pathological features and received adjuvant chemoradiation therapy. No new safety signal observed. Observed adverse event or grade 3 or more adverse event were generally consistent between the treatment group and are commonly known to be associated with chemoradiation therapy also. The immune-mediated adverse events were more common with pembro plus standard of care as expected. Neoadjuvant pembro followed by surgery and adjuvant pembro concurrent with and after post-operative radiation therapy represent new standard of care in treatment of patients with resectable, locally advanced head and neck cancer. Thank you. Over to Sitij. Next speaker.
Well, thank you, Dr. Bhavesh sir. I think a very, very complex trial, but you really simplified it well. Thank you so much. And now I'll invite Dr. Kshitish sir for focusing on the role of immunotherapy in recurrent and metastatic setting. Over to you, sir.
So good evening, everyone. At the outset, I would like to thank Dr. Toprani sir, Dr. Samir Batham, the entire ISO organizing committee for having me in this wonderful meet. So the job which is given to me is to speak upon clinical applications of immune checkpoint inhibitors in recurrent, inoperable and metastatic head and neck cancers. So I think we need to change this. This is a different one. Oh, fine, thank you. Okay, so I will just start with a case study. This is a case of a 55-year-old man, no significant past medical history. He presented with a 6-month history of solid food dysphagia, cough and abdominal pain. In the past month, he had noticed a large swelling on the right lateral neck while shaving. He was in a very good performance status. The routine evaluation by flexible laryngoscopy was performed and it demonstrated a 3 centimeter exophytic mass at right BOT. Biopsy was poorly differentiated squamous cell carcinoma, P16 was positive. A CT neck demonstrated an infiltrative 3 by 1.5 centimeter right BOT mass, multiple non-matted cystic neck nodes, level 2, 3. CT chest and abdomen showed numerous nodules in the lungs and liver, consistent with metastatic deposit. Biopsy of a lung lesion was also of same histology, P16 positive squamous cell carcinoma. The PDL1 by CPS was a score of 5. So a 55-year-old male, PS 0, metastatic, upfront metastatic oropharyngeal malignancies having involvement of lung as well as liver. So this is the summary of the case. And obviously these are the common options which we think of while prescribing one for our patient. be it a combination of chemo with cetuximab or chemo with pembrolizumab or a single agent immune checkpoint inhibitor or only chemotherapy. I am sure there may be other options as well, but these are the usual things which run in our mind before addressing what exact regimen to be given for this patient. So I think in the coming slides, again, I would come back to the case and let us see what should be done for this particular case, be it chemo plus cetuximab or chemo plus immuno or only chemo or only immuno what. So this is what has happened in the last 50 years. It all started with single agent chemotherapy, methotrexate, 5-FU, then came platinum, cisplatin, carboplatin, then came an era of combination chemotherapy, cisplatin plus 5-FU, taxanes came, and then 2006, cetuximab came, the extreme trial, chemo plus cetuximab. Then in 2016, the role of checkpoint inhibitors was published, was established, initially in the second line setting as monotherapy, then in the first line setting with combination of chemotherapy as well as monotherapy. So we have evolved a lot, starting from single agent chemotherapy, 2 checkpoint inhibitors, a combination of checkpoint inhibitors, and I think this is a fantastic journey. So you can see the NCCN, current NCCN guidelines, and it is so much exhaustive that even by looking that close, I'm not able to read this. There are so many different options which are there as of now. If you look into the preferred regimen, the first line regimen, what it mentions is a combination of pembrolizumab with chemotherapy as a category 1 recommendation, as a monotherapy in tumors which express PD-L1, a CPS score of 1 or more than that. And in subsequent line, if not used previously, we can use immune checkpoint inhibitors as monotherapy, be it nivolumab or pembrolizumab. Now, if we see other recommended regimens, there also we see various different regimens, a combination of chemo with cetuximab, and there are various other combinations as well. The combinations of pembrolizumab with a different chemotherapy partner is also mentioned over here. And there are various other regimens also. So the point here is there is so much things to choose upon, and that is why we are discussing how to choose the best option for the patient sitting in front of us. So this is the NCCN guidelines, and these are the ESMO guidelines, the Asian adaptation of that. And the difference which I felt was there is no mention of a specific mention of PD-L1 in NCCN guidelines, but if you look into the ESMO guidelines, there are 2 important things which they highlight. One is the PD-L1 score, and other thing is the using or the platinum sensitiveness of the tumor, whether the patient has been exposed to prior platinum-based chemotherapy in the last 6 months or not, and based on that they have given the recommendation. So generally, if I can simplify that, if a patient has not received platinum-based chemotherapy in the last 6 months, and if the patient is fit for platinum-based chemotherapy, and if it's a PD-L1 positive tumor, what do the ESMO guidelines tell is they mention about using platinum-based chemotherapy in combination with immunotherapy. So if the tumor, if PD-L1 negative, they mention about using cetuximab plus chemotherapy. I'm sure this is not the only thing which we generally look upon before deciding whether to give cetuximab or immunotherapy. There are other variables to it, and be it the site of the tumor, be it the symptoms of the tumor, be it the bulkiness of the tumor, the sites of metastasis. All these things are very, very important. These variables are so much important that everything needs to be considered in toto prior to choosing the regimen. But definitely this is how the guidelines mention about choosing between cetuximab and immunotherapy. Okay, so I think these are the important points which needs to be highlighted. The important thing is we all know in any recurrent, inoperable and metastatic head and neck cancer patient, in their journey they will require platinum, they will require cetuximab, they will require immunotherapy, they will require some other chemotherapy, be it methotrexate or something. Now the real art is how to sequence them, whether to use first immunotherapy or whether to use first cetuximab. I think that's the most important debatable question. And there needs to be some ways how we should select between these two agents. Can biomarker help or not? We'll come to that. What about the combination strategies and focus on special populations? So this slides mention the summary of major landmark trials in the treatment of head and neck squamous cell carcinomas. And if you can see the overall response rates, the initial part, they are the second line trials. What we can see is a 15% or odd response rates with single agent immunotherapy. And then we look into Keynote 048 trial, that was a landmark phase 3 first line pembro plus chemo trial. And if you look into the response rate of combination of platinum 5-FU and pembrolizumab, it is 43.7%. So this shows how we have evolved from second line monotherapy to using it in the first line along with chemotherapy and improving the response rates in our patients. So this is a standard study design of Keynote 048. I just rushed through the eligibility criteria. It included all the sites: oropharynx, oral cavity, hypopharynx, larynx, recurrent metastatic disease, incurable, good performance, it is 0 or 1. PD-L1 assessment was done, but it was not mandatory. And they were stratified into based on PS, P16 status, and PD-L1 expression more than 50, less than 50. There were 3 arms, 1:1:1 randomization, monotherapy arm, pembro plus chemo arm, and the standard extreme arm, that is cetuximab along with cis or carbo plus 5-FU based regimen. The primary endpoint was overall survival and progression-free survival. There were numerous secondary and exploratory endpoints as well. Now, the good thing about or rather the best thing which I like about immunotherapy is the durability which it offers to our patient, which can be seen by this particular slide. If you look, now we have a 4-year follow-up of this particular trial, and if we see the 4-year OS, the 4-year overall survival, let us look into the best PD-L1 subgroup, that is CPS more than 20. So if we are having a patient on day 1 with CPS score of more than 20, and if we are offering him the pembro plus chemo combination, there will be about 1 in 4 such patients who are going to cross the 4-year landmark. And I think this is something which is very, very important to understand. About 28.6% patients, they were alive at the end of 4 years. In the best PD-L1 subgroup. What about in the ones who are not having more than 20, say more than 1 subgroup? Still it is 21.8%. The pembro plus chemo combination arm, the total population is 19. So still it is 20%. 1 in 5 patient will cross the 4-year mark. If you look into the subgroup analysis, not going into much deep details of that, but nearly all favors the immunotherapy arm over the cetuximab arm. We have 5-year results of Keynote 048. And if you look into the overall survival in the entire ITT population, what it shows is at the end of 5 years, in pembro plus chemo, the combination arm, 16% of the patients are alive versus 5.2% in the extreme arm. And in monotherapy also, 14.4% versus 6.5%. And these data are statistically significant. If you look into the CPS more than 1 subgroup, pembro plus chemo, it is 18.2 versus 4.3. CPS more than 1 is the best PD-L1 subgroup. The OS is definitely the highest. The percentage is 23.9% versus 6.4%. So what it shows is definitely higher the PD-L1 score, the better is the survival of the patient, and about 20-25% of patients are living at the end of 5 years if we are starting with pembro plus chemo as mentioned in this trial. Now, one more dilemma is whether to use a single agent pembrolizumab or whether to use a combination of pembrolizumab with chemotherapy. We all want Nobody wants chemotherapy to be given. If the same results can be attained by a single agent pembrolizumab, why not to use it? But obviously the things are not that simple, and there are various other factors which needs to be considered. Generally, if we are having a patient with low tumor burden, slow pace of disease, asymptomatic or polysymptomatic, or patients with different comorbidities which can impact the tolerability of chemotherapy, say uncontrolled coronary artery disease as a contraindication to 5FU, these will be the subset of the patients where we generally prefer giving a single agent. Versus if you are having a patient in which the tumor is in critical anatomic location, say a big nodal mass just nearby the carotid or engulfing the carotids, having a very rapid pace of disease, very symptomatic patients who need a very rapid treatment response, and no comorbidities or patient fit for chemotherapy, this will be the subgroup where we would prefer giving combination therapy over monotherapy. So these are the Society of Immunotherapy Cancer Guidelines for recurrent metastatic head and neck cancers. And this also mentions the role of immunotherapy, pembrolizumab as monotherapy, as well as in combination with chemotherapy as a first-line regimen. Now, very important thing, what happens when one progresses on immunotherapy, the sequencing part which I mentioned, that so there was an analysis done that the patients whom we have started with immuno plus chemo combination, and in second line, different regimens were given. And if we look into the overall response of the entire group, that was 30%. But if you look into the group where cetuximab was given, the response rate was 53%. So the point over here is, first checkpoint inhibitor, second line cetuximab, the response rates are not that bad. So that is the message which I want to convey. And there are various retrospective series also which mentions that post-IO cetuximab does work well. Okay. Again, a very important concept is the PFS2 part. I'm coming to that. First subsequent therapy following progressive disease. And in this particular trial, what happened once the patient progresses on checkpoint inhibitor. Now there can be various regimens which can be given, be it cetuximab or be it chemotherapy or be it a kinase inhibitor. And this was analyzed, and what was shown that about 44% or 44% they received chemotherapy, about 20 odd percent patients they received cetuximab. And PFS2, I think progression-free survival 2, PFS2 is a very important endpoint which is quite under-talked. And I think for immunotherapy trials, this is a very good endpoint. It can be a better surrogate than just PFS if we look into for overall survival. And if you look into this particular endpoint in this trial, PFS2 was longer for the pembro arm in patients with CPS more than 20, CPS more than 1 in monotherapy part. It was similar between arms to the total population. When you look into pembro plus chemo versus extreme, PFS2 was longer for pembro plus chemo in patients with PD-L1 CPS more than 20, more than 1, as well as the entire population. So the point here is PFS2, once the patient progresses, they tend to have a better event-free or a progression-free survival than the extreme regimen. So I think this is an important point to be noted. Role about the biomarkers, I mentioned about PD-L1, and I think in one of the conferences I've heard that it is not a good biomarker, it is not a bad biomarker, but rather it's an incomplete biomarker. This is what I can tell. That's the only easily available biomarker which we have. So let us, and this is something which is very practically possible, doable, and we tend to do it quite often. Does it correlate with response rates? Does it correlate with survival? As far as head and neck cancer is concerned, I think yes, it correlates with response rates, it correlates with survival. I know there are issues with interpretation, more than 20, more than 1 subgroup analysis and all those things, but to give a particular message that is yes, PD-L1 is something which we can consider prior to choosing immunotherapy versus cetuximab as far as head and neck cancer is concerned. Regarding the HPV status and the use of immunotherapy, This was some SP related data from Keynote 012 Checkmate 141, and what it ultimately concluded that if you look into Checkmate 141, overall survival in HPV positive, the hazard ratio is 0.60, HPV negative it is 0.59. The median OS looks nearly similar. So be it HPV positive or negative, it should not influence the decision to treat patients with immunotherapy. Regarding TMB, TMB is, we all know, a biomarker, and more than or equal to 10, this is a cutoff which is used, and we can use a single agent immunotherapy. What about the data of TMB in head and neck malignancies? There were some data from the trials which used durvalumab and tremelimumab combinations. And what it showed was, yes, higher TMB do correlate with longer OS in all evaluable patients. But I think this should be definitely taken with a pinch of salt. We just don't look into TMB and decide between the regimens. Okay. Now, so we had many, this is not only Pembro which is tried in first line recurrent metastatic head and neck cancer setting. People have tried numerous regimens, a combination of IO, Nivo plus EP, Durva plus tremelimumab, a combination of IO plus TKI, that is Pembro plus lenvatinib also. But important thing to note is only one trial as of now is positive, that is Keynote 048, that is the pembrolizumab trial. So we tend to sometimes discuss that all these immunotherapy agents are nearly similar, be it they can work in either PDL1 or PDL1, or whether you use single agent or double agent, you use Pembro or Nivo or Atizo, more or less they're working on the same pathways, they are same. But I think data wise it doesn't look like that, and so that's why it's important to choose that immunotherapy agent which has the best data in that particular cancer. So just a few slides regarding Nivo plus EP, the IO combination versus extreme in the first line treatment. And this is the trial design, Nivo plus EP versus the extreme regimen. No chemotherapy in the IO arm. And if you look into the primary endpoint of overall survival, even in the best PDL1 subgroup, that is PDL1 CPS more than or equal to 20, we can see the hazard ratio of all IO combinations are similar. This is something which we all tend to do very often, using paclitaxel carboplatin as a chemotherapy partner to pembrolizumab, because we all know using cisplatin and 5FU, I think it is cumbersome logistically. And even side effect wise also. So I think this was needed, because this is something which is very routinely used, use a combination of taxane, platinum and immunotherapy. However, it was a single arm trial, Keynote B10 trial, and if you look into the results, the overall response rate was 48.5%, with a median PFS of 5.6 and median OS was 13.1 months. So pretty similar. So I think this combination is something which we can definitely use in our patients, rather than using 5FU based regimen, which is difficult logistically. And response rate also, it's quite similar, 50%, about 50% response rate. Now what about this combination, pembrolizumab plus rituximab, the best of both the regimens, or both the, what do you say, groups, using both together, pembrolizumab along with cetuximab. So yes, there are some data to that. However, it's a non-randomized multi-arm phase 2 trial. But yes, there is some data, and it's given in the guidelines also. In the NCC, in the first chart that I showed, it does mention about this combination also. 33 patients data, and what it showed was, I've come to the results. By 6 months, the overall response was 45%. So yes, it is responding. That is number one. Number two, regarding the side effects parts, yes, it seems well tolerable, well manageable. So yes, this, but still, we need to wait for more data to come. But yes, this combination is also being tried. This is one thing which I wanted to show. So if you look into the landmark of recurrent metastatic head and neck cancers, the positive trials are 048, that is pembrolizumab with platinum and 5FU-based combination, and B10, that was a single arm trial with paclitaxel carboplatin. The rest trial beat IO-IO combination, Nivo EP or Durva, tremelimab, Kestrel or Checkmate 651, they were negative trial. Regarding LEAP 010, using a combination of lenvatinib plus pembrolizumab, it was compared against pembrolizumab only. So lenvatinib plus pembrolizumab versus pembrolizumab, there was no much difference, which was noted. It was considered to be a negative trial, but this combination lenvatinib plus pembrolizumab has not been tried with other regimens. It's a very practical regimen, a very doable regimen, and used in some patients, and the responses are very good. So again, because of lack of data, we cannot promote it, but this is something which is definitely, which can be considered or maybe in future trials, a combination of TKI with IO in head and neck cancers. Okay. Right, so coming to the ASCO 23 guidelines, so we just, do not confine ourselves to just oral cavity or oropharynx and head and neck cancers. Nasopharyngeal cancers, salivary gland cancers also have, role of checkpoint inhibitors, and we should know that in nasopharyngeal malignancies, pembrolizumab or nivolumab with GemCis is an approved regimen, apart from the other immunocheckpoint inhibitors like toripalimab, pembrolizumab or tislelizumab. And even in salivary gland cancers, it is important to look into PD-L1, look into TMB, and in appropriate cases, one can consider giving checkpoint inhibitors to them. Okay, so the problem with immunotherapy, immune-related adverse events, nearly from head to toe, from any inflammation can happen, and but yes, it is important to be vigilant about that, and there are ways to manage them, and I'm sure it is something which should be more you use it, the more you become confident in managing the toxicities of immunotherapy. So with that, again, thank Dr. Toprani sir, Dr. Sami, the ISO, the MSD for giving me this wonderful opportunity. Thank you, thank you.
Dr. Kshitij, sir, and I think this was a comprehensive discussion, not only focusing on the keynote 48, but also on the different combination strategy, focusing on biomarkers, as well as your own practical inputs that really added the value. I'll now invite Dr. Chirag sir for moderating the session and entire faculty for the Q&A session. Yes, sir. All the faculty members to for the panel session. Yeah.
I think let us all sit over here only. Yeah, I also will be sitting. Vivek, Kshitij. So I don't have any slides. I mean, I will have straight questions, and I expect the straight answers from the esteemed panelists. So both Dr. Bhavesh and Dr. Kshitij have very well discussed about the role of immunotherapy. Multiple drugs, they extensively reviewed all the available literature for early as well as advanced head and neck cancers. I will make some provocative statements to ensure that I am awake and the audience is lively. So the first provocative statement that I am going to make is that immunotherapy works everywhere. In all the cancer, it works. We don't know how to identify the base patient. And for the patient where we think that immunotherapy is not going to work, how do we combine immunotherapy with other immunotherapeutic drug or with chemotherapy partner? So there is the long gap in our knowledge that we have tried to fulfill over maybe a decade or a little more than that, and we have reached to a place where we are a little more learned as compared to what we were earlier, but a lot needs to be done in coming years. So what I'm going to do is, both the speakers have done their job very well. They have practically answered every question that might arise for the management of head and neck cancer. But I will talk about the journey of head and neck cancer patients. And in that journey, we will try to figure out how optimally we can use immunotherapy drugs along with the other available modalities. So as it evolved, initially the immunotherapeutic drug were approved as second or subsequent line in the management of recurrent and metastatic head and neck cancers. So we'll start with that, right? So there are three prominent trials of use of immunotherapy in recurrent and metastatic head and neck cancer. Two were with nivolumab, one was with pembrolizumab, 012 study, keynote 012 study, and checkmate 040 and 141 studies. So these trials establish the role of immunotherapeutic agent somewhere down the line, beyond first line. So the question to Bhavesh, you were speaking about early, so I will ask you the question about advanced head and neck cancer, then I will roll over the question to Kshitij. So at what line, I mean second line, third line, fourth line, you would want to use immunotherapy in the patients with head and neck cancer?
So as you rightly told, Chirag bhai, we had last decade, like 2015 or onwards, evaluated the immunotherapy. If I am talking at present in 25, my first preference will be at least second line, not third line or fourth line. But I had a data or I had a convincing immunotherapeutic. Now only that question is whether it was monotherapy or it should be combined with chemotherapy. As Kshitij already mentioned so many trials and you also mentioned. So at present I am definitely agree that we should use immunotherapy in recurrent and metastatic head and neck cancer in a second line.
Kshitij, in second or subsequent line, maybe you will recommend with chemotherapy or single agent?
Right. So to me, it has to be along with a partner. And to me, it has to be with a different form of chemotherapy.
And I will appreciate you can back up your statement with some data.
Yeah. So recently, last year, we published our own data. In platinum refractory cases, where generally the standard recommendation is to use immunotherapy as monotherapy. That is what the guidelines tell. In a platinum refractory case, you need to give either single agent Nivo or Pembro. But what we found in our small study was that in platinum refractoriness doesn't mean refractory to other chemotherapy, say methotrexate. So if you are combining immunotherapy with methotrexate, say Nivo with MTX or pembrolizumab with methotrexate, the responses are quite high. What we saw was the response rate to the tune of 45 to 50%, rather than just 15%, which were mentioned in the trials. So I think because the synergy is very important, and if in a symptomatic patient, in a platinum refractory, difficult to treat biology patient, I think we can use this combination, and this is what I feel.
Right. So one thing that emerges is very important. As Bhavesh said, use immunotherapy early. Don't use it too late. Otherwise, it will remain Ganga Jal only. I mean, before the patient dies, put 2 drops of immunotherapy in patient's vein. So that should not happen. That is first thing. Second thing is that all the trials, Bhavesh and Kshitij, first Bhavesh and then Kshitij, have enrolled the patient with performance status 0 and 1. While most of our patients are having performance status 2 and performance status 3. So will you extrapolate the data and use immunotherapy in performance status 2, let us say first?
So definitely performance status 2 still it's a good I feel rather than 3, because as you rightly tell the real world data or our clinical scenario is that most of the patient is refractory cisplatinum or second line, where definitely, but in the performance status 2 definitely I am happy that I am using immunotherapy. Sometimes even to use chemotherapy is sometimes little bit difficult rather than immunotherapy. So I will definitely, although the trial was in 0 and 1, but to extrapolate that data in performance status 2, I am definitely happy to use immunotherapy.
Great. And how about performance status 3, Kshitij?
Right. So what I feel, sir, is if the patient is symptomatic because of the disease, say too much in pain, and the PS is 2 or 3 because of the disease itself, I think in such scenario, if there is a response to the treatment, his performances can improve also. So I think this performance status should be considered in a clinical scenario. This is
right. So what I make out from the discussion is that if the patient is having performance true, minimal symptoms, not great symptoms, but poor performance status is because of the disease. You can give immunotherapy. You can extrapolate very easily. All of us do that. At least I do that. And maybe single agent immunotherapy may work in these patients. All the trials are with single agent immunotherapy. But if the performance status is 3, and if the patient is symptomatic because of the bulk of the disease, only immunotherapy will take ages to work. And as Kshitij rightly said, that we might use some chemotherapy partner. We have phase 3 data from Tata Hospital using low-dose nivolumab. And a quick line about that trial from Kshitij first and then Bhavesh.
okay. So in my experience, what I feel is, yes, it works. This is what I have experienced that. But if given a choice, I think it is important to discuss with the patient. If there are no issues financially, it has to be standard dose. There is no alternative to standard dose. But yes, if there are some issues, if we find the histology is too bad and we have to give some agent, the OMCT, just only OMCT is not working, and patient is too much of pain, I think adding this is not a bad option. We have seen some very good responses to that.
So Bhavesh, I will just twist the question a little bit, the same question. We have very good data from Tata Hospital. Single institutional trial, but a randomized trial, published in a peer-reviewed journal. So, will you accept that data or not?
As you mentioned, is very important. It's a single institute trial. It was not randomized, and it was randomized, but again, like peer-reviewed journal, but again, not a standard guidelines like NCCN guidelines or ESMO guidelines. So definitely, I love to use that combination, low-dose immunotherapy plus oral metronomic. But again, as it is told, I would also love to use in a full dose also. But some of the problem or some of the part where even I feel that this combination is definitely an effective combination as far as the combination of oral metronomic with low-dose Nivo.
So we have to believe our data, and I will appeal to the people from MSD also to come forth with investigative study on pembrolizumab in various dose schedules with various partners in second or subsequent lines of therapy. So that's it. So first to Bhavesh and then to Kshitij, will you have any preference of one over other drug, nivolumab versus pembrolizumab, in your treatment?
We also discuss various trials like Durva, Nivo or Pembro.
No, I'm talking about second and subsequent line right now.
So at present, all like especially Nivo or Pembro, both immunotherapeutic agent is the same. I had not a specific preference to use or one is better as far as side effect profile is concerned or as far as response rate is concerned.
Kshitij.
Right. So sir, I will tell what I do. I don't know whether it is right or wrong. Say if I am having a patient who is weighing 80 kgs, and if I want to give nivolumab, the dose is 240 milligrams. If I am having a patient who is weighing 40 kgs, the dose of nivolumab is 120 mg. So I think that answers the question that how do I choose between Nivo and Pembro? It is just based on the weight. Nivolumab is a weight-based dosing. Pembro is having a flat dosing. So you don't need to look into weight before doing pembrolizumab.
In Pembro 012 trial, it was 2 milligram per kilogram. So you could do that as well.
Yeah, we
anyway,
do that.
We have two good immunotherapeutic drugs in second and subsequent lines of therapy. The approval and the guidelines show that we should be using single agent immunotherapeutic drug. We have some data of combining with various combinations like oral metronomic therapy and other chemotherapy as well. So as both the panelists rightly said, that if the patient is symptomatic because of the disease, tend to go for a combination. Even though I cannot substantiate that data with a phase 3 clinical trial or with some guideline, but that works in our practice. Now, immunotherapy is established in second and subsequent line, and so logically the step was to move it forward to bring it in the first line. And Kshitij discussed various trials in the first line as well. So because Kshitij discussed that, I will ask the first question to Bhavesh. Bhavesh, we have 3 or 4 options when the patient comes to us requiring the first line treatment for recurrent and metastatic disease. But before I ask the question to you, I will ask the question to Samir, maybe. Samir, patient has a recurrent and metastatic disease,
Yes,
right? And traditionally we call this patient as incurable patients.
We used to call, yes, sir.
We usually
now, yeah.
do call. So how will you pick up, how will you ensure that we don't miss the potentially curable patients from this subset of the patients?
So again, sir, the traditional definition of oligometastatic, which we use in most of the sites, this is one thing where, so suppose a isolated lesion in lung or somewhere else in the body, other than head and neck, is one site where I feel that the chances of cure are quite high. A patient with multiple loco-regional disease as well as distant disease with a poor performance status, probably I'll not be that confident in, going aggressively in that patient.
Toprani, there is no metastasis. It's just loco-regionally advanced disease. So how will you ensure that you don't miss out on a potentially resectable advanced disease?
You are talking about oral cancers.
Head and neck cancer, let us say in general.
Yeah, so the question is, you should not miss the, how do I ensure what?
You don't miss the potentially curable or resectable disease before handing over to the medical oncologist.
Yeah, so it's most of the times it's a clinical decision and based on cross-sectional imaging. So we decide whether we are able to get a negative resection margins or not. So we discuss this in the MDT before we decide that this patient is not going to be upfront resectable. And then we get our medical oncologist into picture at that time.
Right, perfect. So Bhavesh, we have 3 or 4 options. One is single agent pembrolizumab. Other is pembrolizumab with chemotherapy. Third is extreme. So how will you select a particular regimen for your patient?
I think Kshitij mentioned about all 3 trials and extreme trial and compared also extreme trial with immunotherapeutic agent also. And so many years I am very used to use cetuximab that might not be used in a real adjuvant setting or neoadjuvant setting. But with such a data also in 25, definitely I am using now immunotherapy also in a first line setting also. Although OS is not that achieved, but I am happy with the PFS and the response rate also in a first line setting of immunotherapy.
Kshitij, pembro versus extreme versus pembro with chemotherapy.
Right. So what I look into is there are 4 things. Number 1, the site of tumor, how symptomatic the patient is, what is the PD-L1 score of the patient, and how bulky the tumor is.
So if I can interrupt over here, all these factors will tell you whether to give single agent pembro versus a biological drug and chemotherapy combination, right?
Right. So choosing between cetuximab and immunotherapy also. Say if I am having a patient who is having too bulky tumor, too much symptomatic patient, what I expect is a quicker response.
Right.
Oral cavity, too much bulky tumor, very much symptomatic patient, and a negative PD-L1. I would prefer cetuximab.
Right. So symptomatic patient, bulky tumor, so on and so forth. You will not give single agent pembrolizumab. But yes. What about pembro chemo versus cetuximab chemotherapy? How will you select?
Right. So I think in Keynote 048, wonderfully it was analyzed. Chemo plus pembro versus extreme regimen. Right. Now, if we look into the patients who are progressing quickly, they were more in the pembro chemo arm compared to the cetuximab chemo arm. So if I am concerned with that, say a tumor in a very critical location, so I will be worried about disease progression. So in that scenario, I think I would choose cetuximab over pembrolizumab.
And what is the importance of biomarkers in this particular subset?
So say if I'm having PD-L1 score of 100, but still the tumor is in a critical location. Yeah, I would still prefer giving cetuximab rather than chemotherapy. If I'm having a patient with few lung nodules, few liver mets, not much symptomatic patient, a distant disease, no any loco-regional recurrences there, with a high PD-L1 score, this would be definitely immunotherapy.
So, Chirag, there is one online question from the audience.
Yeah.
Dr. P. Ananda Selva Kumar, and his question is, why immuno failed in locally advanced head and neck squamous cell cancer after chemo radiation while it worked in lung and esophagus?
Sorry, ask the question again.
Why immuno failed in locally advanced head and neck cancer after chemo radiation when it worked in lung and esophagus?
So the question is, in a concurrent setting, why the trial of concurrent chemo plus immunotherapy was a negative trial rather than other sides?
So I think let us discuss that when we reach to that particular topic. We are at present in the recurrent and metastatic disease. So you were telling something about biomarker. Yeah, Bhavesh, what about other biomarkers like HPV or maybe EBV? Will you do EBV in any of the head and neck except nasopharynx?
No.
Okay. So about HPV, will that help in your selection of the immunotherapy versus cetuximab?
No.
No, really. Then what about the other biomarkers like TMB and the other biomarkers?
So I am doing that biomarkers, but still with that tumor TMB or PDL1 again, as Siti also told, that at present I am doing that biomarker, but that decision that on that biomarker still is not depend only on that particular test.
Right. Now I will try to bias the entire audience as well as my panelist. By my impression, I feel that if the patient is in good performance status, I will not be giving single agent pembrolizumab. I will want to give a combination with chemotherapy. Yeah, I mean, there are patients who are not fit for chemotherapy and where single agent pembrolizumab may be useful. So Kshitij, if you have selected, I mean, the same question comes here as well. Performance status 0-1 versus performance status 2, and I think we have discussed that in the second and subsequent line. So that same rules will apply over here also, right?
Correct.
Okay. You only said in your practice, you usually give taxane platinum in combination with either pembro or cetuximab.
Yes.
So, what is the reason? Why is so?
Right. So one of the reason is 5FU. Logistically, it is challenging. It needs a long hospital admission, a long line. So everything is so long in 5FU. And this is a simple daycare procedure, quite convenient logistically to the patient, and I think the responses rates are quite equal. And there are some scenarios where you cannot use 5FU. Say in a cardiac patient, you cannot use 5FU. So in that scenario, or if you want to give a weekly regimen, you cannot give it weekly 5FU. I mean, the data is not that strong, but you can give weekly taxane and platinum, and we are very well comfortable using that regimen.
Right. So, my suggestion to everyone is to pull the data together. Don't let it go waste. Let us collate our data. Let us publish our data. Let's publish our experience of immunotherapy or maybe cetuximab with platinum and taxane, either 3 weekly or weekly, and in whatever form that we are giving. So that will give very strong data to back up with our decisions. Kshitij, if you have 100 patients that you treat in your OPD, and let us assume you are in SCG Ahmedabad, all your patients are affording, not like my patients. So if all your patients are affording, right? What proportion of the patient you will select for single agent immunotherapy? What proportion of your patient you will select for pembro with chemotherapy and cetuximab with chemotherapy? Roughly.
Right. Right, so only immunotherapy will be just 5%.
Okay.
Pembrolizumab plus chemotherapy would be, say, 25 to 30%, and rest would be cetuximab plus chemotherapy. If I want to say the reason for that, I think it is the site of the disease. We see a lot of oral cavity cancers, and the data of pembrolizumab is more into oropharynx, HPV positive disease. So I think that is the reason.
Now, having established its role in first line in recurrent and metastatic disease, the logical step is to move it forward, to bring it in the earlier stages of disease, and Bhavesh discussed all those trials very well. Before that, Toprani, please stop me when, or ask me to go quick if I'm running over time.
We have 10 more minutes probably.
8 to 10 minutes.
Yeah.
So we will try to complete in those 8 to 10 minutes. Toprani, the question comes to you only. Checkmate, Keynote 689 study was for resectable patients, right? How comfortable you are in referring your resectable patients for whatever neoadjuvant therapy, and why?
So it's a very good question, and a very challenging situation also to treat these resectable patients with systemic therapy. Forget about Keytruda, with any systemic therapy. And the most important thing would be to consider for organ preservation. For example, you want to preserve a mandible, and there are some trials ongoing for even in India for organ preservation, for particularly for mandible. And the Lisa-Licitra trial is very well known to all of us. And I think a significant portion of patients, they were able to preserve the mandible after giving neoadjuvant chemotherapy in resectable oral cancers. And very few patients underwent adjuvant radiation as well. So there's a big advantage. But this needs to be studied very carefully in the Indian scenario, particularly with a lot of submucous fibrosis and all those things. The other organ preservation area of interest would be for the tongue, whether most of these patients who are resectable but locally advanced, would we treat them with systemic therapy in a neoadjuvant setting so as to but we don't know what will be the margin of resection later on post neoadjuvant chemotherapy. Majority of these patients will respond well, but we don't know yet what will be the margin of resection. So again, that is a dilemma.
Will you want to raise any other points?
No, sir, I guess this was probably one of the valid point which we in fact encounter in our day-to-day practice. Especially when we, as sir mentioned about tongue patients who have locally advanced disease, they are technically resectable, but we usually consider taking into account the morbidity of that procedure versus if the patient can be offered neoadjuvant chemotherapy along with some kind of immunotherapy, and if we can, preserve the function.
So provocative question, Kshitij, you are in the MDT, and let us assume that you are in the real life situation, you are in the SCG MDT room with Toprani and with Samir, right? And there is a resectable patient with whatever involvement, tongue cancer or oral cancer with mandibular involvement or whatever weird situation that you might think of. And then you are suggesting Keynote 689 with immunotherapy 2 cycles as neoadjuvant, followed by surgery, right? And they are on your head that why the hell you want to give immunotherapy? Why not chemotherapy? Both of them said that chemotherapy works very well. So how will you convince them?
So, thing is, I can only convince them if I am convinced.
So, for me, did you convince them or not?
Definitely, I will convince Kshitij that immunotherapy, like as I mentioned in early, the trials and the results are very good, and we should, rather than chemo, we all know since so many years that neoadjuvant chemo is definitely a role, especially even in operable, where surgeon especially feels that bias it is borderline or we want at least organs preserving. But I think even a single agent immunotherapy works very well.
So to save the time, I will take over on this question, and then I will take my statement, and then I will ask all the panelists whether they are agreeing or not. So for giving neoadjuvant therapy for borderline or unresectable, I don't think there will be any questions. We will give chemotherapy. We don't have the data about immunotherapy yet, right? But for resectable, advanced head and neck patient, and that's what we are seeing day in and day out in our practice. We are either operating the patient or and then followed by chemoradiation for resectable patient, and that's the state of art. We might give neoadjuvant treatment for some situations like mandibular involvement or tongue cancer where we want to de-escalate the surgical or radiation treatment. But there is enough number of patients, there is large number of patients who eventually come back with a recurrence or with a metastasis. And is there any way we can take care of those patients, right? So traditionally, if you look at the literature, locally advanced, resectable patient, half of them are cured, half of them do come back. How can we cut down on those half of the patient who have a recurrence of the disease? And that's where this trial helps. So 2 cycles of neoadjuvant therapy, neoadjuvant immunotherapy, followed by whatever standard treatment that you are offering, standard of care versus continuing 14 cycles of pembrolizumab in total, neoadjuvant as well as adjuvant. And this trial has shown the superiority over standard of care in terms of everything, recurrence rate and disease-free survival. And for overall survival, it is early data. It is not shown to be statistically significant. But Bhavesh, the trial was initially started in 2019. The first presentation was in 2019. And 2024, we have some data now. So OS data will come, but we have the surrogate endpoints showing that this is a good trial, this is good data. So with this reintroduction of this trial, Samir, you will accept this trial or not?
Sir, although we have not used it practically in our clinics, but yes, if the data is promising, science cannot be, the facts cannot be denied, sir.
Topranik Kshitij is convinced now. So are you convinced or not?
Right, so
We have seen some fantastic results in few patients, but the problem is that is not being done under a trial setting, and we have not documented that and published it anywhere. But some of the patients, we get an unexpected response. So we do discuss about these issues at times.
So glaring example is lung cancer, resectable lung cancer, where if you give adjuvant immunotherapy versus neoadjuvant immunotherapy works better. There is a theory that has to be proved in multiple organs that if you give immunotherapy in presence of the disease in situ, it works better as compared to if you take out the tumor and then you give immunotherapy. Neoadjuvant immunotherapy works better with organ or the tumor in situ, right? We will slowly start getting convinced about Keynote 689. I will stop that discussion over here, and I will move to that question which came from the audience about why did concurrent immunotherapy and radiation fail in head and neck, and why did it work in other cancers? So, Kshitij, do you have any answer to that?
So, if you look into the data of
Avelumab.
so Avelumab trial was a negative trial, pembrolizumab trial was also a negative trial. So 2 trials, large trials, they were negative. And I think to answer why it was negative, I think I can just speculate. I think head and neck cancers, I think they are quite different than other cancers.
Absolutely.
Right, so that can be one thing, that tumor microenvironment or whatever tumor biology is maybe different. So no any other possible explanation I can have at this point.
So majority of head and neck are squamous cell carcinoma, which are locally advanced disease. The majority of lung cancer are adenocarcinoma, which have the tendency of having distant metastasis quite often. So that may be another thing. But looking at the data, Bhavesh, you will say that concurrent immunotherapy and radiation should not be given, right?
Yes.
Okay, wonderful. Anybody will give adjuvant immunotherapy?
Yes, definitely.
No, what is the data? Do we have any data, adjuvant immunotherapy?
Not at all.
Absolutely.
Not at all.
So even though you will want to do, perform a clinical trial, you want to evaluate, but we don't have any data as of now. Now, I will tell you one situation, and this is my last question, and then we will stop the discussion. There are patients, Toprani, you also will agree that in your practice, there are patients with field cancerization. The cancer may keep popping up. Second cancer, third cancer, fourth cancer, all of them are maybe T1 or early T2, N0. You keep on operating the patient and you desperately feel that someone should attempt something to stop the recurrence in the field cancerization patient. And we have some data of immunotherapy in this type of patients also. So Kshitij and then Bhavesh, do you think that immunotherapy might help in this type of situations?
Yes, but yes, there is this hypothesis, or there is this there are some data, but not very strong, convincing data to use it in our real-world practice. So I think maybe time can tell us. But I think, yes, this is a very important practical problem which needs some answer, maybe in future with using immunotherapy or by using simple metronomic treatments or whatever to cover that 2 years of time where you have maximum recurrences. I think that can, but as of now, we cannot use it.
Right. So trials are ongoing for Pembro as well as nivolumab. We can say that we are doing immunoprevention trial, like we did chemo prevention or breast cancer prevention trial with tamoxifen. So we covered, thank you very much all the panelists, we covered from Gangajal to immunoprevention. And I think we tried to bring out the relevant points in our practice. So you want to say something?
So to summarize, Chirag, for the benefit of the audience, we have got more than 300 people online and we have got the audience here. Can you summarize for the audience, what do you think in your practice? We have been practicing since last 30 years in India. So what do you think is going to be the future of immunotherapy going forward? Whether it's oral cancer, whether it is other subsites, for example, larynx and hypopharynx, and what about this role in neoadjuvant setting versus vis-a-vis its role in adjuvant as well as recurrent metastatic setting? So can you summarize?
For recurrent metastatic disease, when we failed the chance to use it in the first line, you should use in second or subsequent line before the patient becomes too sick. So that is the first thing. No biomarkers required. Give it, you won't get that chance once again. And there are occasional patients who are long-term survivors in the second and subsequent lines as well. For the first line, it is still getting established, and we are trying to learn about how to optimally use immunotherapy. Even though we have a very strong Keynote 048 trial, which substantiates the use of immunotherapy in the first line. Kshitij very well said that if you use the immunotherapy as the first line, PFS2 also is better. That is the better surrogate endpoint as compared to PFS for overall survival. So you can change several endpoints. But in here, what I will recommend is that improve your surveillance, pick up the recurrences early, and before the recurrence make the patient too sick, take the opportunity of giving immunotherapy. But if the patient is already sick because of the bulk of the disease, maybe we may require some more clinical trial practice data about cetuximab chemotherapy versus immunotherapy chemotherapy. We need to do more work about evaluating immunotherapy or maybe cetuximab with platinum and taxane. That data is there for TP extreme, but phase 3 data is lacking for immunotherapy and platinum taxane. And we need to do a lot of work in early stage disease for unresectable patients, for resectable patients, and for immunoprevention. So we have very good data with Keynote 6 and 9 in resectable patient who are high risk, and we need to look at our own data. We need to start using it ourselves and be comfortable with that particular trial. So I think that's it.
Yeah, so
About IO plus IO.
Yeah, so IO one trial Kshitij mentioned, but that was IO versus cetuximab chemotherapy. And to that extent, I will want to do something like Checkmate LA trial, where it was 2 cycles of chemotherapy with Nivo-AP, followed by Nivo-AP only, so that we don't lose the patients early because of early progression. So something like that, maybe IO combination with chemotherapy, maybe fewer cycles of chemotherapy. We don't want to induce toxicity because of chemotherapy in this patient. And so we need to do a trial of proving this concept.
So the workload of head and neck cancers that we have in India, I am sure that we'll be able to generate, if a trial is designed, maybe multiple trials would be required to really establish this role in different scenarios in all head and neck cancers. So with that positive note, I think I thank all the panelists, Dr. Chirag, Dr. Bhavesh, Dr. Kshitij, and Dr. Sameer, who is our executive committee member. And I thank MSD for having organized this meeting. Thank you. You want to say something?
I think one of the excellent meetings that I have attended, and I really want to sincerely thank all the faculty and especially the ISO committee. I want to end my thanks with what Dr. Chirag sir actually highlighted in the beginning, that immunotherapy works everywhere, but it's very, very critical to identify the right patients. And I think this event actually highlighted the appropriate patients by highlighting which are the comorbidities, which are the appropriate combination of the therapies, and what's the role of biomarkers. So I think that question probably would have answered well, and ultimately it will lead to the better patient outcome. That's the intent of both MSD and even the ISO and the faculty. So thank you everyone, and I want to thank all the participants for the patient listening who are here, and as well as who are on the online. Thank you all.
Thank you.